So our next speaker today is Farley Cleghorn. Now, I could go on for 20 minutes introducing Farley because we go back, more than 20 years. And Farley, as I see him, is not just an excellent academic, but he's also one that is where the rubber hits the ground. He's where the action is. And Farley is currently Chief Knowledge Officer and Global Health Leader at Futures, and he's leading enormous international teams trying to do the real thing on the ground in terms of global health. So Farley, thank you very much for joining us this afternoon and talk to us about an implementer's perspective about what it means to integrate services. Over to you, Farley.
Thank you, Slim. It's a pleasure to be here. Thank you to the organizers for this session, which aims to look beyond the clinical findings that are so important to our field. I have the honor of delivering an implementer's perspective, and I am going to talk fast. We'll have the opportunity for questions after. Implementation, as you all know, is how the rubber hits the road, as Slim says. And we see integration, as we have seen it for HIV, integration more broadly as an effectiveness and efficiency mechanism to get more impact. And the reason that is so is we get synergy from integration. And there are all kinds of published studies on how this can be done. And of course, we are coming at it from the perspective of the largest vertical program for a specific disease ever undertaken, and that is PEPFAR. Of course, combined with the global effort, it makes it the most significant single disease effort ever undertaken in public health. And how then do we extract some of those lessons to apply more broadly to health? Well, currently, when we talk about implementation, we talk about implementers like my organization, Futures Group. Essentially, we are brought in to deliver technical assistance and capacity building. So in the past, we used to talk about health services delivery, where we're assisting countries to deliver health services. Now we are assisting countries to build their capacity to deliver their own health services. And as I said, we've done this for many, many diseases. Someone mentioned maternal and child health and reproductive health and family planning. And we've been trying over time to integrate HIV in reproductive health and HIV in family planning. And we've had some successes, albeit limited. Essentially, when we're delivering technical assistance and capacity building, we're trying to help countries to fill what I call the analytical gap, which is how do they know what to do using the information that they have, and how to fill a management gap. We're asking them to do more and more and to deliver more and more impact. And essentially, they're doing it with the same enterprise infrastructure that they had prior to expansion of programs. And of course, we have an evaluation gap. How do we know how much progress we're making? We have a resource gap, and that resource gap is beyond the fiscus, which is how much money is available, but also what are the people and other resources, infrastructural and other, that's required. We also have a bit of a contention between, or dynamic tension, between whether you do something from the ground up or you do it from the top down. And I think this is a false dichotomy because you need both. And my colleagues on the panel will actually speak quite eloquently to how they are attempting to do integration at the health facility level, and you'll see the lessons from there. But we do need some typology to help us talk about this issue. And I think a relevant one is the social ecological framework for disease and health promotion. And you all know this framework. We use it every day. This is the framework that UNAIDS has adopted, that WHO promulgates, and it actually is quite adaptable to the notion of health in the social sector, because health and education and social cohesion and water and sanitation, nutrition, you can go on, that is all within the social sector when we try to socially promote better health, better wealth, better education, etc. And of course, the reason that this is useful is that it allows us to separate out interventions that are useful for the individual, for the proximal risk factors for disease, for example, HIV sexual risk, from those that are contextualized within the community and society. And that's useful because when you try to mix these interventions into packages, as we have tried to do for HIV, you run into a number of issues. And if you try to mix interventions for the whole of health, for all of the health priorities of a community or a country, you run into similar issues. Perhaps we should remind ourselves what we take for granted in development, and that is when we think about interventions that we support in a country's program or just support in general based on the evidence, we say, does it work? And this is established by, of course, usually randomized controlled trials, but also additional work beyond trials. Then we ask ourselves, is it cost effective? And usually cost effective at scale. And we have various benchmarks for determining this. Is it one by the GDP of the country or more than one by the GDP? If it's one, we say it's very cost effective. Then we ask ourselves, is it operationally feasible? Can this actually be done in the setting? And of course, many of you will recall the debates we had about implementing ART outside of the developed world and implementing medical male circumcision. The list goes on and on. Can we do complex things in resource-limited settings? And then we ask ourselves, is there fiscal space for it? Who is going to pay for it? Where are the resources coming from? If you can answer all these questions, then essentially you say, yes, these are interventions, or this is an intervention that we can promulgate as an intervention in countries that don't have the resources we do. And one note about cost effectiveness that I always try to remind people is that cost effectiveness is not about the cheapest interventions, but cost effectiveness is about whether the additional or incremental cost is worth the additional, rather incremental benefit is worth the additional cost. So similarly, when you think about what I just said, defining what relevant interventions are, you can think about programs. What is a program? A program is a logical set of interventions that can be bundled together to address the health priorities of a population. And we can restrict that definition to HIV, or we can expand it to all of the primary health care needs of a population. And you've heard Debbie Burke say this many times. She didn't invent this, but she's been saying it a lot. Doing enough of the right thing, which is the right dose, at the right time, and her right time is right now, for the right people. And what that translates into is coverage, quality, and intensity of proven interventions, as we described in the last slide. And that eventually leads to the change that we're trying to get to, which is population-level change to reduce the impact of the conditions of interest, for example, HIV. There is some missing science in how these combine, and this has been part of the effort we have had to understand, for example, combination prevention for HIV. As you know, we are easily, or we can more easily look at biomedical combinations and how they impact HIV transmission and HIV sequelae. It's harder when we add outside of the biomedical how we get to reasonable combinations that address the proximal and structural risks of populations around the world. And finally, one other contextualizing point is that when we think about populations and their health needs, we have to think in terms of not just the public sector, because we tend to have that conversation usually within the public sector, but we have to think in terms of both the public and the private, and the sector in between, which is the not-for-profit, faith-based NGO, CSO communities. These together make up the ecosystem of health. So I'm not going to be, this is not shameless, but this is one model that we have used to try to help countries to understand their health priority needs. Many of you will recognize the Goulds model that my organization has been promulgating over the past 20 years. And the Goulds model, which has, of course, been adapted by UNAIDS into the epidemic projection model, it uses an impact matrix that says, what do we know about the disease? What can we tell about where it is going to go, particularly for the population of interest, say a country of South Africa? And what are the resources required to deal with this disease based on the evidence? And if you change your priorities, how will that change both the outcomes or the impact and the cost of doing that? And we have applied the same thinking to include not just HIV/AIDS, but all of the priority health conditions of a population into this One Health model, which was developed by John Stover. And what it does is it's really a strategic planning, costing, and analysis tool that allows any jurisdiction, whether it's a country, it's a province, it's a state, or even a local government or authority district, to understand what costs are by disease priority and what are the health components that are necessary to deliver those interventions in order to get the impact, which is to change the outcomes of interest. So this is really about getting all the right people in the room with the right information, making a plan, operationalizing that plan, and looking at the results, and then changing it as it goes. One of the words that Debbie Birx uses quite often here is we need to be able to pivot so that you get information back that says you're doing it not quite the way you want to, let's pivot and do it in another way. I'm using the One Health tool as an example of how you can do this. We've done this in about 6 countries so far. We've used the Goulds model for HIV/AIDS in about 75 countries, which is the basis for planning for HIV. So it's calculating costs, it's looking at the health system requirements, and I like to think of this as a health ecosystem. And we are looking at what is the expected health impact, and then we're helping whoever is in charge. And if we're looking at the public space, it's the Ministry of Health, but it's also the government as a whole, because the Ministry of Health, guess what, doesn't control the fiscal purse strings, and we need the people who control the fiscal purse strings, and the Ministry of Planning, and the Ministry of Education. We need all of them in the room. So, and by the way, someone mentioned Richard mentioned the Sustainable Development Goals. Well, you can actually align your planning so that you meet your objectives under both the MDGs or the SDGs, which are to come. And what that does is that it helps you to both understand your situation, your health situation. This example here is what is the mortality profile in a country, and this is from 2014, and it shows you right away, HIV is the biggest cause of mortality in Botswana still. Therefore, we have to have a very effective program for HIV in Botswana. And, you know, it also says, by the way, that malaria is at 2% of overall mortality. So when you think about that, you want to be able to take your malaria information and construct a program that allows you to deal with malaria where it is happening. As it turns out, malaria in Botswana is only happening in 6 local government authorities. So you want to focus your malaria program there. That's just an example. It also allows you to set some priorities on interventions. And we are able to rank all these interventions based on the evidence. And as we said, RCTs are the gold standard for evidence, but there are other ways to judge effectiveness. And you can rank those interventions and set your cutoff so that you're only delivering interventions that have a likelihood of success. Yes, thanks. I've been told that I have to really hurry it up. I think what I really want to do is give you the sense that there's this process and this ecosystem that you can use in order to go from epidemiology to costing to really management for impact. That's really what we're talking about. And these tools already exist. We are using them in many countries. And it allows a country to decide what is it that we want to change, what are the available options to change it, What are we going to invest in? What are the expectations we should have? How will we measure our success? And just an example here is Botswana did not have a cervical cancer screening program, and they have decided to have a cervical cancer screening program. This is a good thing. Guess what? We can plan for it. We can implement it. They can plan for it and implement it. We will help them. So I'll stop there and say that there have been many, many lessons from the AIDS epidemic from both a planning and analytical standpoint as well as a costing and impact standpoint that we can bring to bear on the whole of primary health care in a country. And those tools can be applied, they should be disseminated, and they will help countries to deal with their priority health conditions. Thank you.